right, guys. So we're going to come to some treatment options, and so I've tried to do this in a way to stimulate some conversations. So like me and Ravi can talk about this till we're blue in the face, and Keith can add in, and Jens is being very polite and very German, but like kind of I can assure you he has his own opinion. So the question was, what are the things that you should know about treatment decisions as a newly diagnosed patient? And we hear a lot from pharmaceutical companies about, drug X versus drug Y, 3-drug combination versus a 2-drug combination. And so their presentation of the data is all about registration of new drugs. It's nothing to do with improving the outcome for patients. It's about how do they make a profit. And it's there's nothing wrong with that, Rick. But really, if you want to make patients' lives better, you have to talk about patient-centric ideas. And there's simply not so much money around to do that sort of clinical study. So the data is much less available and probably less good because it's not financed properly. So this question is, I guess, important to me and Ravi because we both expressed an opinion that's completely divergent from one another. My contention is that for almost all patients you should aim for MRD negative states, because I think ultimately it'll be associated with better outcomes. And Ravi's saying, while he probably agrees with me, he's not really up for that interpretation at about this point in time. So this is the iceberg approach to myeloma. So you look in the blood or the bone marrow, and really you see it, but most of the disease is subclinical that you're not aware of. And I'm trying to suggest here that you can measure the amount of disease bulk by the number of polar bears that are present in the body. So at presentation, you have lots and lots of disease. So you have 5 polar bears worth of disease. So the treatment goes induction, which is to reduce the amount of polar bears, and you get down to 2 polar bears, and then you can collect stem cells, which are less contaminated by tumor cells, so they should be better stem cells. So the idea is you don't give the disease back to the patient when you reinfuse the stem cells. You do the transplant, the disease goes down further, and it's quite clear now that post-transplant consolidation works, which is probably the same chemo given after the transplant. And then it's very clear that prolonged exposure to drugs does something that we never anticipated 5 years ago, and people continue to respond over time, and ultimately we want 10 and 15-year survivors. So where does all this nonsense about Darwinism, evolution, genetic diversity fix into all of this? So the idea would be that you debulk the disease so there are less cells there that can get subsequent damage. You want to use treatments that modify the stem cell biology so they don't grow so quickly, and use novel drugs to modify and select for good performing clones. Maintenance could be modified. It might be like giving drugs for a chest infection or antibiotics, that you use one antibiotic for a while, and when you think you're getting resistant, you swap to another and then swap back. Using the immune system is clearly going to be important. And what is very, very important is that in the past, people used cytotoxic chemotherapy, which is a cause of mutations, and was actually probably making the cancers worse at some level. So be aware of that. So again, I'm picking on Ravi because I like him rather than for a fight. So he said that there was no data that when you swapped treatment that you couldn't improve outcomes. And so I thought I'd show this data, which is not meant to be about treatment, it's about the concept. So if you're not responding to one treatment, so in this case it's a combination of an alkylator plus an IMiD drug, if you respond poorly and then swap to something that has a different mechanism of action, in this case a proteasome inhibitor like Velcade, can you deepen responses? And if you deepen responses, are they associated with better outcomes? And the answer to that is, in this case, is yes. That if you have a poor response to an IMiD drug combination, you can swap to a proteasome-containing combination, and it will improve your time without disease, and it will, I think, turn into an overall survival benefit, although it doesn't look like it does on there. So it will improve your progression-free survival. So you can think in that fashion about response-adapted therapy, and so there is some evidence that changing treatment will increase the number of MRD negative states. This is just more data on the same thing. Should have been hidden, which is going to confuse me now, but never mind. So response-adapted therapy is possible. So what is the best drug to use up front? And so Velcade had, in combination with VMP, which is widely used in Europe, and when combined with cyclophosphamide as well, has about 10 to 15% of severe neuropathy. So in the registration trial, 15% of people had significant enough neuropathy that they couldn't walk or couldn't function in daily life. So it's been important to avoid that. And there's a study on the Amgen slide outside which compares carfilzomib dex to Velcade dex. And so carfilzomib seems to be a more active agent than Velcade. So using carfilzomib up front is probably good for patients because of response rates and reduction in side effects. And so again, this is problematic, but I'm going to skip through these, which was a French study of carfilzomib to a study we did in the UK. So following on that, 300 people treated with KRD compared to a CRD or CTD combination, and you get much better response rates. And so carfilzomib becomes a very clear and potentially good option for induction. So then the question, I think, for patients is transplant still the preferred option if you can tolerate it? I mean, everybody's keen to know that. You hear a lot of bad things about it. It makes you sick, it makes you lose your hair, but it's still like a lot of experience with it, and it seems to work. So this is a study that was done by the French, really, so a combination of the French and the people from Boston, and I think it provides pretty unequivocal evidence that at least a single transplant remains the optimum treatment for people in the upfront setting. And there were 3 other trials that were consistent with this. So they randomized RVD induction, which is a widely used triplet, against transplant or no transplant. In this case, it was 5 extra cycles of RVD. And so the responses were better in the transplant arm, and they're shown in the brackets there. And the PFS was, PFS means time without disease. So your disease-free period was longer if you were treated with the transplant. The survival benefit wasn't there, but I think that's because it's too early to look. To see the benefit of transplant, you have to look at 13 years, and so we're not going to know the answer to that. And so you have to use the evidence on what you can see, which is there's a survival benefit when you're free of disease. So I would argue that in view of the increased response rates, better time free of disease, that transplantation remains the optimum treatment up front. And so then this is a bit more controversial. What is the role of double transplant, so a tandem transplant? And so like there's a good English saying which is a poacher turned gamekeeper. And so in this context, I'm a poacher turned gamekeeper in that I swore blind for years that a double transplant was not a good option, and only an idiot would do what hadn't worked the first time a second time. Okay, so I'm owning up to my own inadequacies here. But I think the evidence starts to grow that a double transplant is actually better. The bloody Germans, as we say in England, do it to everybody. The Italians do it all of the time. And so what is the evidence? So my pals, okay, let's start with this. So this is the first French study, and you can see that double transplant did nothing in terms of survival until you got out to 72 months. But then the curves start to separate at 72 months. So if we're talking about getting 10 years plus survivors, that's the part of the curve that you're interested in. Ravi showed the maintenance curve. The curves didn't separate till about this point in time. And so I think the randomization said that the double transplant worked. And they interpreted that if you were a slow responder, you did better if you had a double transplant. And so that became the practice across France. So double transplant for slow responders became one of their standard indications. So then there's the Dutch. So you have to look around the world for this evidence. So like, it's quite funny because the Dutchies and the Germans from Heidelberg got together and did a big study. And the Germans, bless their cotton socks, did 2 transplants.
You're going to be mad at him with his British accent.
And then the Dutch, who were a little more conservative, didn't do a double transplant, did a single transplant, exactly the same trial. And when they came to look at the data between the two outcomes, the double transplant did much better. And it was something that people really, really didn't expect. And the final bit of evidence is that the European Myeloma Network did a similar approach, and again, the double transplant came out better than the single transplant. So I don't think it's to be dismissed out of course, and I think it does offer patients something if you're prepared to go through the second transplant and the side effect profile. Yeah, that's the data. But then comes the stamina trial, as Ravi will tell me. So what do you make of the stamina trial, Gareth? So it's a well-conducted trial done by I think it's the Southwest Oncology Group. There's a 3-arm randomization, and they tried to address So this is, like Ravi showed you, this is the only study really that's ever been shown, powered to show a survival benefit. And there was a survival benefit, not as big as you might have expected, but a definite overall survival benefit. When you put that with the trial from Jens's new institution, I think the evidence suggests that you should have maintenance after stem cell transplant, and all patients really should have maintenance lenalidomide. And then the question becomes, where do you go next with this? And it seems to work for high-risk and low-risk patients, so irrespective of your risk status, you should have it. And the question then is, how do you make that better? And I think you can add proteasome into it, you know, an oral proteasome inhibitor added to this would be potentially really good. There's a study addressing that. You could add daratumumab to it. And so a lot of the question going forward, and this is the last slide, is about should we maximize remissions, aim for MRD status in all patients, and when they've hit MRD, do you adjust the treatment with immune therapy to control the disease long term? And then you follow up with MRD testing, image analysis, and if you see early relapse, change the treatment approach. And one thing about the duration of maintenance, it's really important. If you get 60% of people to 10 to 15 years, maybe more, you're over-treating people after a while. So treatment to progression becomes very, very difficult as we're more successful in these younger age groups. And so we have to think of a time duration that's effective, but at which you stop and then simply monitor patients using MRD tests. So I'm going to stop there.